Recording. Yeah. Today we will be just continuing our discussion which we started yesterday about how to target an oral exam. The basic concept is the same, even if it is long case or short case. The only difference is that in usually in long case, they are trying to check your clinical judgment as well as your patient dealing. They are also checking it and how to interpret the data being given to you. The only difference between the international exams like FRCA or Irish Fellowship is that they are usually not bringing the patient and they are giving you the data. Okay. And there are a number of problems which are there in the same patient. And then they are asking you to interpret. They're asking you about the pathophysiology. They are asking you about the investigations and then how to make a differential diagnosis and how to give anesthesia care. Okay. So the only difference in Pakistan, or I'm not sure what's the format in India, but usually in most of the part of the world, they don't bring the patient in anesthesia exam. They are only giving the data, and you just have to interpret it and manage it. Okay, so the only extra thing will be the clinical examination and history taking, which is there in our exam. Okay, so we will just start by one um, sample case. I will just give you a hint. Just a second, please.
नहीं ये तो ਹੁੰਦਾ नहीं शायद ਇਹ ਟਫਨ ਦਾ ਸ਼ੀਸ਼ਾ ਹੈ
Can you please mute the mic?
ਇੱਕ ਤਾਂ ਨੋਰਮਲ ਸ਼ੀਸ਼ਾ ਹੁੰਦਾ ਜਿਹੜੀ ਆ ਲੱਗੀ
Actually, I'm not feeling well. I have sore throat. I will just try to speak out as much as possible. Uh, This is an excellent book for um, oral exam preparation. Okay, I will just try to choose a case in which we have. Okay, I think this seems to be a good case. Has any of one of you see this book in the folder?
yes sir I didn't read the marker
Sorry for this inconvenience. Uh, just a second. Just trying to reach the page. Okay, so we will just take example of the single buzzword will be that it will be a thyroid case. Okay, so I will start with it that you have a patient with thyroid. So what do you think will be the possible problems which you should be attending in a patient with thyroid disease? Okay. We yesterday we discussed about it and we said that first thing to know is the demographics. Okay. So in demographics, what you will be asking about the age, sex, occupation, what else? What else you will be
weight and
asking?
height of the patient
Yes. What else?
family history
Family history. Okay.
सर मैरिटल स्टेटस पूछेंगे इसका
Marital status. Okay, what else?
Passion of the patient is
Be a little loud, please. Just a second, please.
signals are not right.
Actually, sorry for this inconvenience. I am just trying to open a file. Just a second. Actually, in the long case, the usual approach, if you make a general approach, then it becomes very easy for you to prepare the case in the limited time which you will have. Okay. Okay. So as I told, name, age, sex, address, occupation, socioeconomic status, smoking, addiction, alcohol, this BD pan, IV drug abuser, any infectious disease like hepatitis, AIDS, marital status, birth history. Okay. Last one child, this is for females, menstrual history, anesthesia history, difficulties, complications, GA versus spinal before in the previous surgery, surgical history, blood transfusion history, drug history, any hospital admission, and past medical history. These are all you can count it in. Just a second, it's not coming. Sorry, it's not showing it. I don't know. I'm just trying to write it here. But anyways, all this up till here, this usually is the demographics. Okay, the patient demographics. So what will be the possible if you are just think about thyroid disease. So in this history, what can you find among these things? You can find some problem in the menstrual if it is the female. Okay, in the general history which you take. And thyroid disease is more common in females or males?
Emails.
Females.
I think it is
Emails.
more common in females, if I'm not wrong. Okay, so this will be from the data. Okay, now comes what will be in the uh, I think it will write here. Just a second. Okay, what will be the features of hypothyroidism? What will be the common signs and symptoms of hypothyroidism? Yes, please. Anyone?
So we can take them system wise. Like
Okay,
in CVS, there will be bradycardia with hypertension,
ready.
low cardiac output. In the
Hypertension, hypertension and heart failure.
hypertension is heart
Heart failure.
failure.
Okay. Okay. What else?
And then in the GIT, there will be the gut will be slow, so patient will have constipation, reduced absorption, reduced digestion.
Actually, you are absolutely right that we should try to tell in systematic way, but sometimes this can distract you. Okay. Again, try to tell the things which are more important. So as you told about CVS, the other important system is metabolic
Respiratory system, metabolic.
and neurological system. Okay. Because when metabolism will be slowed, the reflexes will be slowed. Okay, patient will be more drowsy. There are chances of
Cold intolerance,
OSA.
myalgias.
Yes. Okay. So you will be focusing on these signs and symptoms if you are trying to rule out hypothyroidism. Okay. So uh, because usually in hypothyroidism, either you will have a patient with visible goiter. Okay,
Mm.
or there may
Yes, sir.
be not visible goiter. Okay, and because if you have an obese patient in which the landmarks are not very clear, so you will not be able to pick it. Okay, so in that scenario you should be knowing the features of hypothyroidism and hyperthyroidism as well. So here there is menorrhagia, here there is usually amenorrhea. Okay, and there is heat cold intolerance, here there it will be heat intolerance. Okay,
Yes,
there will be tachycardia, there will be atrial fibrillation, like which will be in the investigation, but palpitation. Okay,
yes.
what else? Tremors.
Tremors, anxiety in hyperthyroid,
Sweating.
depression in
Sweating also.
hypothyroid,
Sorry.
weight. Patient has weight loss in hyperthyroidism and
Weight
he's
loss,
obese in hypothyroidism.
sweating. Okay, a sleep disturbance. Okay,
Sir, eye features in hyperthyroidism. It's
yes, eye
ophthalmologist.
features, eye features. What else? What else?
Are the main.
Okay, so there will be some questions which will be specific. Okay, specific to thyroid, and there will be some generalized questions or generalized, sorry, yes, there will be some generalized question. Okay, so if you just have a look here, I have just tried to compile the generalized questions which you should be asking or you should be looking in any patient. Okay, so sleep pattern, and among this sleep pattern, this posture, whose mic is not okay. So in the sleep pattern, you will find PND and orthopnea. Okay. So orthopnea and PND is a sign of what?
Heart failure, sir.
Tra-
No
Necessary,
doubt
not
of
tracheal
heart
necessary.
failure.
compression.
Yes,
Heart
it can
failure and
be.
retroexternal goiter.
Retrosternal goiter, yes, fine. But it may be the cause of heart failure, may be of cardiac origin or respiratory origin. Okay. And it may be also a feature in OSA. Okay. In obstructive sleep apnea patient, or even in hypothyroidism, there may be orthopnea. Okay, and nocturnal dyspnea, it is more near to the heart failure. Okay, so nasal blockade, snoring. What is the significance of snoring? This is related to sleep apnea. Okay, and if you find a history of nasal blockade and you are having a surgery in which nasal intubation is indicated, then you have to rule out the risk versus benefit, and you have to discuss with the surgeon. So what is the interpretation that if even if you are having a table viva and there is something in which there may be like in the data they have given you that the patient snore at night, or it's a young baby with recurrent respiratory tract infection, or the disease which they are telling there are chances of. So you should be thinking in mind that nasal blockade is one, maybe one of the symptom. And if they are asking you to have nasal intubation, this may be a problem. Okay, so you have to be uh, interpreting the possible sign and symptom in the patient. Okay, I'm just trying to keep both of the both sort of listeners who are preparing for an exam like in Pakistan, or preparing for any international exam. Okay, because even if they have given you the data, maybe some of the data will be indicating towards some of the signs and symptoms which I have just tried to chalk out. Okay, so eating drinking pattern, maybe it is a sign of diabetes. Okay, if patient is feeling hungry and feeling thirsty, polydipsia and then polyuria, so this is one of the sign of diabetes mellitus. Okay.
Even in
Uh,
hyperthyroid, the patient eats more, but there is no
yes,
weight gain.
because metabolic rate is more. Okay.
Is more.
So what else? This anemia, weight loss, anorexia, jaundice. It may be sign of some like uh, liver disease, or it may be sign of some cancer. Okay, so in cancer, because anemia is evident in the form of pallor. Pallor may be a sign. Pallor may be a symptom. Jaundice may be a sign. Jaundice may be a symptom. Okay. Okay, so eye symptoms: red eye, burning sensation, eye ache, ptosis, excessive and decreased lacrimation. I have not written here is ptosis. Sorry, this one, protuberant exophthalmos. Okay, so this may be a sign, as it was obviously it will be a sign, but it can be told by the patient that I am feeling I am noticing that my eyes have become prominent. Okay, so this is one of the thing which you it is these are the factors which I have written here is are the generalized signs and symptoms which you can look at in any patient. Okay, ear symptoms like pain, discharge, or hearing loss, especially if it is there is some neurological problem, this may be a sign. Joint deformities, so joint problems, pain, swelling. What are the things which may be related to joint problems? Yes, anyone, please.
So airway difficulties, neck
Airway
mobility, or
difficulties,
jaw
one thing.
mobility.
Like there will be mobility in the immobility or limitation of the movements of the joint. This is one thing. Number two, what else?
Patient positioning may be difficult. We
Very
have to
good,
take care.
very good, very good. Patient positioning. Number two, number three. Think about it.
So
The patients who are having joint pains may be taking steroids or NSAIDs, or if it is part of rheumatoid arthritis or ankylosing spondylitis, there will be associated problems. Okay, so patient may be only saying joint problems, but you have to look into it that if the patient is only saying I have pain in my joints, so you the related questions which you should be thinking in your mind is the possibility of patient taking NSAIDs. So NSAIDs will be leading to this acid problem like acidity, ulcers. Ulcers will lead to bleeding. Bleeding will lead to anemia. So this is the correlation. Then patient may be because of steroid, sorry, NSAIDs, there may be this patient is at risk of acute kidney injury. Okay,
Acute
in
kidney.
the in the perioperative period, if you have some more risk factors, if a patient, for example, is diabetic and he has joint problems as well, he is taking NSAIDs, the examiner is not tell you anything. This is what you have to interpret and tell, that if the patient is diabetic and also old age or obese or any joint involvement, then this is the thing which you should be considering, that this is a risk factor for acute kidney injury. Okay, and if the patient is taking steroids, you have to consider two things: the side effects, the complications related to steroid, and you have to replace the steroids. So this is the interpretation of this symptom. Okay, what else? This patient may be taking some supplements of joint supplements or vitamin D or some things like that, calcium supplements, which can calcium may be related to if
Injury because of smoke inhalation is probably there.
okay. So this is the thing. Okay, anemia. What is the significance of anemia? Yes, please. Uh, uh, the people
our
who are going.
oxygen carrying
Yes.
capacity is reduced in patient having anemia.
Oxygen carrying capacity is reduced, and when you are see anemia, you as an anesthetist you have to see whether it is compensated or uncompensated. Okay, because if the patient is decompensated, this may be a more bigger problem to the anesthetist. Okay, so the further symptoms for related to anemia may be palpitation, dizziness, headache, and pallor. So other associated signs and symptoms which you can see. Urine bowel habits, frequency, quality, any associated. There may be maybe because urine infection, there are more chances of patient having sepsis. So if then there is an old guy or a patient which is having Foley's catheter is at risk of development of UTIs and sepsis. Okay, and one thing related to the Foley's, there is another complication which is related to Foley's, repeated Foley's catheter. What is that?
So infection
Yes.
and stricture formation.
Structure formation is surgical. And you will be, this is, we are just trying to exercise our mind. So this is something very atypical. Maybe you are not expecting it. It is latex allergy. Okay. The patients who are receiving multiple Foley's catheterization are at risk of development of latex allergy. Okay. So this is how you will be interpreting. Okay, nasal symptoms, sneezing, congestion, post nasal drip, allergy. This is more important in if you are having a baby. Okay, these symptoms are more significant in, sorry. Okay, so these are more significant in babies because if there is nasal obstruction and there is repeated or repeated RTI, or if the patient is currently having significant nasal symptom with foul smelling sputum or like, so this will be a factor to delay a elective surgery in, especially in pediatric age group. It will be in adults as well, but it is more significant in pediatric age group. Okay, so asthma. So if you are thinking about asthma, you will be, how much are the episodes, how is the severity, aggravating and relieving factor, treatment need and frequency, compliance to it, hospital admission or mechanical ventilation before it, nebulization, inhaler, tablets, steroids. Like if, for example, if some patient has asthma, what anesthesia care you should be changing? Just a mind exercise. Yes, please. Yes, Afira. If you have a patient with suspected reactive
there is
airway
possibility
disease.
we can avoid general anesthesia and when go for regional if there is a possibility. The first of all, if patient is in asthmatic patient, we try to minimize the manipulate the patient's airway.
Okay, one thing.
Yes.
What else?
Other than that, sir, if we have to go for GA, we have to be cautious about using the different drugs. We have to avoid all the histamine releasing drugs like atracurium, morphine, hexamethasone,
What else?
and for
Patient might be on
inhalation.
steroids. We at induction we have to consider about the steroid
Neil,
replacement.
try to speak a little loud. Even
Might be due to noise, due to the traveling. Better I stay passive.
no,
There
no,
was
you
some
speak
mistake
out. Just
area.
speak loudly, please. Just speak loudly.
Is it okay now?
Yes.
Yes.
Yeah. In asthmatic patient, as I told, the first of all, if there is possibility, we avoid to general anesthesia, try to minimum interfere with the patient's airway. Second thing, now we think about the patient's asthmatic, how it was controlled. We have to take the history about his asthma control and how was the severity. We can ask about the patient's history. Is there any admission in the hospital due to aggravation of this
Actually,
asthmatic or
this we have discussed.
isolation?
Move forward. Move forward.
Okay.
Move forward.
Then we also consider about the steroids. Might be patients on inhalational or systematic steroids. We have to replace it
Okay.
at time of inductions.
Okay.
And about
You are not.
if
You are
we
not
go for
telling the.
the Sorry.
The most important thing you are not telling. You are telling the things which you have already discussed in a few minutes ago.
Okay. Then now about the ventilation means
No,
intraoperatively we have.
just a second.
Sorry.
Just a second. You have to avoid airway manipulation in light plane. Okay? You have to,
Yeah.
because more
Yeah.
there will be more chances of brisk respiratory brisk reflexes. Okay?
If
Reactive
there is
airway
possibility,
disease,
we can use supraglottic also
supraglottic airway
supraglottic
device will be one of
yes
the
device.
choice.
Yeah.
Don't try to avoid initially, as we actually, this is not recommended in for induction at all. Actually, isoflurane or desflurane will be irritant, so you have to avoid them. You have to avoid the histamine releasing drugs. NSAIDs may also be avoided. Okay, because they some of the NSAIDs, especially
Yes,
aspirin, is
20%, 15 to
associated.
20% patients are atypical. They have aggravation with the use of NSAIDs.
Yes. Okay. So these are the things which you should be considering. Okay, Afira, be ready for the next question because you also have to participate. Okay. Uh,
Sir, I recently joined. Sir, what is the question? What topic we are discussing?
Actually,
I
this
was
is
busy with the patient. I'm on the
no
duty, sir.
problem. No problem. No
Ji.
problem. So we are discussing the journal approach for evaluating a patient or interpreting the data which you have. It may be presented in the form of written data given to you, or it may be like in the long case, you have to take the questions, you have to take the symptoms, and you have to look the signs, and you have to interpret, make up your mind that if patient has some symptoms or some signs, how will you anticipate? This is clinical because some people just try to just cram these words, or just people sometimes they are only trying to ask the question and they don't know what is the interpretation. So we are just trying to just think about it. We are just doing the mind exercise that if you find some symptoms, what will be the interpretation? Okay. So at the moment, asthma patient, just you join at this point, what will be the what will be the, if you are giving anesthesia to a patient with asthma, and as I told that we have to avoid the drugs which can cause bronchospasm, you have to avoid manipulation in the light plane of anesthesia, and you have to use deep plane of anesthesia for the intubation and extubation if possible, if there is no contraindication for deep extubation. Then what about the ventilatory thing concerns in a patient with asthma? Would you like to do something?
Yes, sir. Yeah, yes, sir. Sir, I will keep the ventilator settings according to patient condition. Like mm, tidal volume is, I will keep the volume control mode.
Why volume control?
Um, Sorry.
Why
Um,
volume control?
so preferably, I will prefer pressure control ventilation
Okay, what else?
because patients have already high
Maybe
may
don't
have
don't say that.
may have
Listen, asthma
may
patient
have
may be normal, so you maybe may
okay,
have, you may
may have
have
high
problems, so it
expiratory
is better
pressure
to use pressure control. This is one thing.
pressure
And the
control.
other thing is
Uh-huh.
that the asthma, in the asthma, problem is in the expiration or inspiration.
Expiration.
So
There may be
probably
The
hindrance in the
main thing,
expiration, so they may develop the autopeep, and so we have to increase their expiratory
expiratory
phase.
time,
So we will
relatively you
expiratory
may
time,
might need to correlate with the patient condition, and maybe you need to have prolonged expiratory time. Okay.
expiratory time. Yes.
Yes. Okay,
Uh,
so this is
yeah.
something related. That's how you will be interpreting. Like if, for example, we missed it, I will just repeat it here. If you have a patient with jaundice, so similarly, you are thinking that there is something bad with the liver. So in the interpretation, you will be saying that you will be avoiding the drugs which are metabolized by the liver, or the drugs which can cause further damage to the liver. So you will be reducing the dose of paracetamol if you are having thinking any significant liver dysfunction, and then you will be avoiding the drugs which are metabolized by the liver, like
like
long acting
like benzodiazepine,
benzodiazepine, morphine, or anything which can
opioids in general.
decompensate the patient. Okay, you
Hmm.
prefer to use remifentanil or medications which does not cause significant harm to the liver. Similarly,
Yes,
you may be avoiding joint NSAIDs, thinking about avoidance or judicious use of NSAIDs because maybe patient may have some bleeding problem, coagulopathy.
cardiac.
So this is how you will be interpreting the data which you are asking, or you are having the history in the data provided to you. Okay, so this is the
Yes,
most one of the most important thing, physical activity. So physical activity will be telling you what? Physical activity, if you are asking about physical activity, it is asking you
about the
Cardiac status.
functional capacity,
functional
cardiac
capacity.
status,
You say what will be the word
meds,
for it? Meds.
meds.
Meds. Okay. Oxygen utilization. Okay, because there will be stress during anesthesia. So whether the patient is able to tolerate the stress or not. Okay, so you have to quantify for elective surgery, the MET should be more than 4. Okay,
Yes, yes,
so and then if it is there is dyspnea or chest pain, this will be a sign of dyspnea, may be because of respiratory problem, dyspnea may be because of heart failure.
cardiac problem.
Similarly, and dyspnea, how you quantify according to what is the
NYHA
classification?
classification. NYHA
Uh,
classification.
Yes, yes. Okay. New York Heart Association classification for heart failure. Okay, and
Yes.
actually it is the same. Uh, and it is Canadian classification for
Okay. Uh,
angina. Okay.
sir, Canadian and NYHA is the same. Both are same.
No, not the same. The
Similar.
symptoms are the same. Mild, moderate, severe is the same. But if one is with the dyspnea, okay, and one with the chest pain. Okay.
Okay, NYHA is about dyspnea and Canadian is about chest pain.
No,
And
and New York Heart Association for heart failure.
but it includes the symptom of dyspnea. Classification
Yes,
is based on the dyspnea.
heart failure, and you are quantifying it with the severity of dyspnea. Okay,
Okay.
whether it
Yes,
is at
please
rest.
just also classify the Canadian. You know, it will be easy then to remember uh, the degree of means angina with the
Jamil, we don't have time to discuss each and every classification. I have to finish everything. Okay, we will we can do it in separate setting when we are doing heart. Okay, but now if you have mentioned it, if it Canadian class 1, 2, 3, 4, if it is at rest, it is 4. Okay, if it is on mild exertion, it is 3. If it is on moderate exertion, it is 2. And if it is moderate to severe exertion or there is no, it is 1. Okay, so usually we go quantify like that. If it is
yeah,
occurring
yeah.
at
This
it
was my
rest,
aim. You know, we
it's
have
4.
any confusion regarding any topic, but better discuss that topic
Yes, no problem.
with
So
yes. Thank you.
similarly, there is chest pain on at rest, it is 4. Chest pain on mild exertion, 3. Moderate exertion, 2. And severe exertion or no, it is 1. So similarly, if it is for, if you are quantifying it for heart failure, we will say as shortness of breath. And if it is for chest pain, it is with Canadian. Okay. Understand, Afira?
Ji sir. Yes sir.
Okay. So just a second, where is it? Okay. So chest pain, dyspnea is a sign of heart failure or angina. And this is what is this intermittent claudication? This is sign of peripheral vascular disease. And whenever there is peripheral vascular disease, it may be this vascular spasm, like it occurs in Raynaud's phenomena. but it may be because of atherosclerosis. So whenever you find this symptom, even intermittent claudication, there is pain while walking, you have to rule out ischemic heart disease as well as cerebral vascular disease. Okay. So for cerebral vascular disease, what questions or what thing you should be thinking? This will be about any neurological problem, any sign symptoms related to TIA or this one
Stroke.
any stroke. Okay, so this will be even if you are only finding this symptom, you have to probe further regarding the chest pain or this one neurological problem. Okay, the cerebral vascular disease, ischemic heart disease, peripheral vascular disease, they can be in one patient. Okay, and all these patients will be leading to arrhythmias, this stroke and heart failure. Okay, so this is how you will be interpreting. Okay, so other symptoms like I will just go further in detail. Actually, we discussed in detail recently about the cardiac evaluation. If you can see that discussion, it will be easier for you to understand, because I have to finish all this. I'm trying to um, give you an idea how to approach in a long case. Okay. So cough, if you are having cough, this may be of respiratory origin, this may be of cardiac origin. So you have to roll in our part of world, they are asking frequently about TB. Okay. So this night cough with low grade fever, this may be a symptom of TB. So they are asking tuberculosis a number of time in our part of world. Okay. So hemoptysis maybe there, this may be, if it is hemoptysis with cough and there are some weight loss, this may be heading towards lung cancer. Okay, so similarly, if they, even if there is valvular heart disease, mitral stenosis, or there is heart failure, there may be cough with sputum. Okay, productive cough with sputum, there may be frothy sputum as well. So swelling, so what about this symptom of swelling, or if you see it, it is edema. And if you patient is saying, they can say you about facial swelling, feet, sacral area. Okay, so what will be the differential diagnosis for it? Any
There may
problem?
be any hypertension, any
Okay,
kidney problem, kidney failure, renal failure,
okay, heart
heart
failure,
failure,
renal failure, liver
congestive heart
failure,
failure.
liver failure even. Okay. So, okay. So prominent veins in legs and face, this may be a sign of, like, for example, as from where we started thyroid, there may be signs of Pemberton sign, which we do. Pemberton sign, do you know about Pemberton sign? You ask the patient to elevate the hands above the head, just like hands up. And if there is some obstruction, there will be flushing of the face. If there is any problem in the um,
Sir, so
inlet
superior
of
vena cava syndrome symptoms will be
yes,
appeared.
yes,
Okay.
yes. Okay, it can occur in retrosternal goiter. Okay. So GIT symptoms like nausea, vomiting, jaundice, diarrhea, bloating, acidity, rigor. If the patient has frequent diarrhea or vomiting, there may be some electrolyte imbalance, there may be some infection going on. Okay. So, and if there is history of regurgitation, acidity, this patient will be at risk, more risk of PONV as well as rigor aspiration. Okay. Hematemesis, melena, abdominal hematemesis, patient may be anemic, patient may have some liver problem. Similarly, melena. Okay, tenesmus uh, is painful defecation. So it may be a psychological sign. It may be in inflammatory bowel disease. So inflammatory bowel disease associated with other this autoimmune disease. So if patient is giving you history of this thing, you have to rule out other problems. Okay. So eating, drinking, bowel habits. This will be giving you urinary symptom. We have already discussed. This may be a sign of some urinary this one kidney problem, as well as if it is in a male patient, it may be due to enlarged prostate. So when there is enlarged prostate, you have to rule out if there is any obstructive uropathy. There may be heart failure. You are only having symptom of this urinary frequency urgency, but the patient has enlarged prostate, and maybe patient is having obstructive uropathy with the disturbed urinary function. So that is the significance even with the urinary symptoms. Okay, if there is urinary stone, there may be history of hematuria, maybe patient may be anemic. And I will just give an example of one of my very sharp friend, and he never failed in any exam, and he was failed in the long case in Pakistan because he missed the symptom of hematuria, and the examiners were irritated because this patient has diabetes and hypertension. So he just tried not to, he did not give too much stress on the symptom of the patient, and he just tried to manipulate the examiners by dragging them towards diabetes and hypertension, and actually he was failed because he had not elaborated only the history of hematuria. Okay, so
The
whatever patient,
patient was having diabetes and having the symptom of hematuria, and she could not ask the symptom of hematuria
like he could not
or
probe,
the.
like I will tell you in detail, but which how you should be interpreting the data and
Mhm,
how you should be presenting it. Okay, but the bottom
okay.
line is that whatever symptom patient is giving you, just try to think that what can be the associated things. Okay,
Mhm,
so
okay.
this is similarly in addition to urinary, this patient might be taking steroid if there is some this nephrotic syndrome or things like that. Okay, and maybe history of NSAIDs. So okay, so nervous CNS symptoms like conscious level IQ, muscle weakness, neuromuscular pain, and neurological deficit. So whenever you are asking, you have to ask about the main any neurological symptom which patient can have, like any motor problem, sensory problem. Okay, like the main sense of hearing, vision. Okay, so these will be the if you are the patient is telling about any history of pain, you have to ask about these things, any aggravating relieving factor, any associated symptom. Okay, if the pain, and in any patient, quickly you have to ask or evaluate almost, there may be some addition, I will show you some other files, but these are the symptoms which you have to ask in any patient, because you just think about it. In these question you have ruled out any problem related to heart, any problem related to kidneys, any problem related to liver, any problem related to neurological symptom. Okay, so you just think about it and you will find that almost all the questions are being asked, but the way you have to ask, because you should have you should be spending not more than uh, 8 to 10 minutes in history and 8 to 10 minutes in examination, and the rest of around 5 minutes, because 5 minutes will already be lose. Even if they are giving you 30 minutes to prepare the patient, I will suggest you keep your watch and try to finish history within 10 minutes, and next within 10 minutes you have to do the examination, and at the same time you should be noting down the positive symptoms. And as I have just given you the insight that how you have to interpret, like if patient is telling you any symptom, you have to interpret what will be the possible problems. Your mind should be tuning at that time. Okay, like if for example patient is having history of drug IV drug abuser, this may be, this patient might have some infectious disease like hepatitis, AIDS. So in the whenever you are telling, you have to note down that you have to tell about the occupational preventions which you have to take in this patient. Okay, you understand? So just make your, this is a sample. You can make your own set of questions which you have to ask in any patient. Even if visibly you find thyroid, for example, you find a big thyroid, but you still have to ask these questions. Okay. Okay. Similarly, the examination, there will you will find a number of way to do the examination. But my suggestion is that if you are starting from one side, go from one side to the other side, and if you are doing something while the patient is sitting, try to finish the things which you can do in sitting position. And then if you are asking the patient to turn towards opposite side, and you are doing some things in the back, you try to finish the things which you need to do in the back. Okay, so that the the patient is not irritated, you are not disturbing the patient again and again, because examiner will be absorbing you what you are doing. Okay, so so try to do like in the hand, you can find sweating, you can find hand grip. Maybe there is some, if there is some tremor, you can find it. If there is some weakness, you can find it. Okay, similarly you can see any signs of anemia, clubbing, cyanosis, chylonychia, what you have in the liver failure. What is this called as? The hands which are very red. I forgot the name. Can anyone recall?
Palmer erythema.
Palmer
Palmer
erythema.
erythema.
Okay, Palmer erythema. So you have to like I've written here. Okay, I was just observe pallor, sweating, tremors, size, shape, contractures. If you have contractures, this may be a sign of rheumatoid arthritis. Usually, it is there in the hand, Dupuytren contractures, and a lot of very difficult names. So you can see these things. Okay, and swelling of the joints, inflammatory, though it may be, maybe you are only finding pain in the joints in the of the hand, but maybe this is there is something hidden for you, that is rheumatoid arthritis. So you don't have to miss anything. Okay, then you are checking the pulse, try to compare the pulse. Then you can do the same at the same time, you can do the blood pressure. You can do, if you are in the history, if you find that you may be needing arterial line, you can do the Allen's test. Just show the examiner you are doing it in a quick way. Okay, and then skin turgor for the dehydration, and then at the same time you can do the reflexes in the hand. Okay, you can do one reflex of this in the hands. Okay, in the wrist you can do the if you are thinking any neurological problem. Okay, and then as I told you, cyanosis, clubbing, chylonychia, hemorrhages in the forearm. You can see at the same time, you can see how is the possibility of the veins of IV cannulation. Okay, similarly you can find some scratch marks, tattoos, IV drug abuser marks, fistula. Okay, if there is fistula, you don't have to measure the blood pressure, you don't have to take IV lines on that side, you don't have to take the arterial line on that side. Okay, similarly you're doing, as I told you, the reflexes. Then if you go to the neck, you can do the lymph nodes, you can do the thyroid examination. At the same time, when you are reaching uh, uh, the oral cavity, you can do the tests related to evaluation of the airway, as well as you can do the nerves. Similar, at the same time, you can do the gag reflex. You can check the facial nerves. You can check the. You can ask the to balloon to put air in the mouth, and you can like in the same go. You will be quickly doing the tests. Okay, you understand?
Yes, sir.
Okay, so this is just, I again say that this is just a default. You can alter it, but if it is better if you make your own plan and a generalized plan, so that you will not believe that there are incidents of patient missing airway examination because they are overdoing the systemic examination. Because if you, for example, try to finish one system at one time, maybe you will take a lot of time and you forget. So try to do the things which you are seeing, like you are taking this all this thyromental distance, sternomental distance, mentohyoid, receding chin, tracheal deviation, thyroid swelling, Pemberton sign, as I told you, and that the distances, the mouth opening, that the dentures. Okay, so you can do everything together. Okay, and similarly, you will find something in the face, as I told you, jaundice, anemia, redness. Just have a look and you will understand what I'm trying to see. So say to you, hygiene, mouth opening, jaw protrusion, incisors gap. I've just tried to compile everything. Nasal patency, and at the same time, you can ask about the sense of smell, and then you go towards the. Ideally, the examination should be up to the mid thigh, but you have to just tell the examiner that would you like me to expose the patient, and usually they will say okay, no problem, you can just proceed like that. If especially if it is a female patient, you will not do the examination like that. Okay, so similarly I will tell you that whatever uh, things you want to do from the from the front, you do in the front at that time, and then the things which you want to do from the back, you do in the back. I'm not going in the details of the examination because maybe we can discuss in a separate time. I'm just giving you an overview at the moment. Okay, so now also you take the blood pressure, heart rate, respiratory rate, temperature, height, weight, blood group. So these are the things which you should be doing in every patient. Okay, and then on the basis of all things which we have discussed, demographics and all the medical condition and all the signs which you find, now you have to chalk out the risk factors. Like as I told, you have to mention, just have to try to know the AS status of the patient. You have to see the meds, you have to see the New York Heart Association, or if there is any has any presence of heart failure or this one angina, you will quantifying it. And you have to find the active cardiac conditions. Active cardiac conditions are written in the form of major predictors in some of the books, and intermediate and active cardiac condition some of the book. You can see them. These are decompensated heart failure, acute or recent MI, severe valvular heart disease, severe arrhythmias. So these are the active cardiac conditions. Similarly, clinical risk factors are in some books they are written as intermediate predictors, and they are compensated heart failure, old history of MI, CVA, okay, and
Stable
renal failure.
angina, stable,
Yes,
unstable,
stable
diabetes,
angina,
CRF.
previous history of MI, compensated heart failure, history of stroke, and then, CRF with creatinine more than 2, and
Diabetes,
insulin
insulin
dependent
dependent.
diabetes mellitus. Okay, pulmonary risk factors, cerebral risk factors, pulmonary risk factors you will find in the detail, but there may be patient related, anesthesia related, and surgery related pulmonary risk factors. You have to chalk them. Okay, and it may be like, for example, low albumin is a pulmonary risk factor, upper abdominal surgery is a pulmonary risk factor. Okay, if the patient is coexisting COPD, this is a risk factor. So similarly, you will just chalk out the pulmonary risk factor. Cerebral risk factor, like for example, in any patient in which you are giving hypotensive anesthesia. So this is a cerebral risk factor. A patient is undergoing cabbage, patient is on cardiac bypass. This is a cerebral risk factor. Okay, and similarly, there you can find a number of risk factors like that. Similarly, renal risk of acute kidney injury, like for NSAIDs, diabetes. You are using the drugs which are like steroids, immunosuppressants,
IV
chemotherapeutic.
contrast,
Sorry,
IV contrast,
IV,
nephrotoxic.
IV contrast, any surgery in which there is hypotension. Okay, it is a renal risk. Hypotensive anesthesia, as I told you, any patient with the massive fluid shift, like aneurysm surgery, like spine surgery in which bleeding can occur. So these, like, thing is that you, this thing should be in your mind. If you, this will be in your mind, it will be easier for you to proceed. Okay, so I have just tried to compile like spinal cord risk factor, similar to about almost similar to the cerebral risk factor, but it occurs in aortic clamping, cross clamping during. Okay, so thromboprophylaxis risk. Not thromboprophylaxis, there is thromboembolism risk, it should be. So thromboembolism, there may be some patient factor, like any patient with obesity, any prolonged surgery, high age. I'm not telling each and everything. You can
Pregnancy,
pregnancy,
pregnancy.
OCPs, that there are a big list, and you divide it. All these risk factors usually patient related, surgery related,
And
anesthesia
surgical
related.
related,
Okay,
anesthesia related.
so you just chalk out in that way. Then PONV risk factors. So PO&V risk factors, female gender is a PO&V risk factor. Use of opioids is a PO&V risk factor. Surgery, any surgery in which there is involvement of vagus nerve, there are more chances of PONV, like in laparoscopic surgery, laparotomy, and middle ear surgery. Okay, so things like that. Aspiration risk: any patient with emergency surgery, gastroparesis, renal failure, liver failure, diabetes. So there will be risk of aspiration risk. I have just compiled it, and then you just think what are the reasons for it, and you make up your mind, and whatever you find in the history and examination, you have to say that in this patient there is aspiration risk, in this patient there is PUNV risk because of this thing. So no, you will not miss anything, I guarantee you. I guarantee you that if you prepare your patient like this, even if it is table viva, you just have to assume that these history can be there. So if it is anything related to it, you will say these things. Okay. Risk of hypothermia and care needed, extremes of ages, and any problem in which you are using a lot of irrigation, ambient temperature is very low. So things like that. So hypothermia is a big problem. It will cause coagulopathy. It will cause delayed metabolism, delayed recovery. So hypothermia is very important, and care, especially if at any patient at risk, you will be even more cautious. Okay. Airway assessment and plan, we have discussed before, because you have to make a thorough airway plan. Then spine examination for any central maxillary block, as well as to see as edema, and if you find edema or things like that, like if there is kyphoscoliosis, there will be problem. Then with the spine examination, you can say, just keep this thing in mind, that you can say the word ultrasound, spine ultrasound. That if you have any doubt, you can do the spine ultrasound to see the midline, to see the distance between the skin to the space, and any deviation. Midline, the level of vertebra, the distance from the skin to the vertebra, the level of vertebra, and the midline. Okay. So this may be an additional thing which you can keep in your mind. IV cannulation and invasive lines, if you need, you can, during while you are doing the history examination, think that maybe this patient might be needing any surgery in which you need more IV lines, and which might need invasive uh, lines, or like arterial lines. So you can do these things while you are examining the patient, or while you are interpreting the data. Multidisciplinary team. So I will ask I would like someone else to participate. And if you have a patient, Dr. Sorry, Dr. Priya, uh, is where is she gone? Okay, Dr. Aiza, you also have his exam, am I right?
Yes, sir.
Yes. For example, if you have a patient with a placenta previa, okay. So what multidisciplinary team would you like to discuss the patient with? Just think. You have a
Sir, first I discussed the patient with the obstetrician, gynecologist, and I also
okay,
involved the hematologist uh,
okay.
for the availability of blood products
Actually, this
and
is blood bank.
listen,
This is
blood
blood
bank.
bank. Okay. Then
Okay. Yes, sir.
obstetrician. Then
Then, sir, I obstetrician and hematologist.
let her talk, please. Aiza, please continue.
Sir, obstetrician and the hematologist.
Just a second. Just think. Consider ICU as a separate intensivist. Okay. Then
Okay.
what about if you find to have acrita? There are
Surgeon.
chances in creta or acrita. So you need general surgeon. You
Yes,
need
sir. General surgeon.
urologist. Okay. What about
Okay.
interventional radiologist?
Yeah.
What may be the need for it? They can embolize They can embolize the internal iliac vessels. Okay. Even
Vessels.
even
Okay.
if you are having a known patient with the placenta previa or low hemoglobin or blood group, they sometimes in some centers they place the balloon so that in between, if they need, they can just inflate it. Okay. So
Okay.
this is the role, because
Okay.
this is the remember one thing, in all patients, try to find multidisciplinary team. So blood bank and hematologist, and then neonatologist, because uh, maybe you need neonatologist. Then what else? Anything else you are thinking? Surgeon, urologist. Okay. And you have to involve the
Yes, sir.
OR, OR, OR staff. You have to brief them, because this patient might
Okay.
need massive transfusion, blood transfusion. Okay. So OR logistics will be requiring is the
Okay, sir.
temperature of the room, availability of the cell saver if possible. Okay. And rapid infuser system. Okay.
Yes, sir.
And blood warmers. Okay. So in this way, you have to think. You will find in every case some involvement of team. Okay, in almost every patient you will find at least one or two teams. So when you are preparing it, keep this in mind, that you
Okay,
have
sir.
to think about any multidisciplinary team. Okay, then you if now
Okay, sir.
now you see that there is some surgical. So as we discussed yesterday about the surgical technique, about the surgical urgency, about the mode, positioning, the incision, level of anesthesia required, level of analgesia required. Okay. Then as similarly, I have written here position related problem. So then you have to plan. You are taking the history examination, and then you are making the possibility of the surgeries, which may be, because they can ask you any surgery. But while you are taking the history and doing the examination and interpreting the data, you should be anticipating that what question they will be asking you. Because if you anticipate and plan that this will be the question, it will be easier for you to answer. Okay. So you will also be thinking that what special monitoring would you like to do. In addition to standard 1 and standard 2 monitoring, you need neuro monitoring. What special monitoring you may need, Afira? Yes, please. In any patient, just think, just try to just what special
So
monitoring,
in which
any patient,
specific
just think about any special
uh,
monitoring which you can require in operation theater from your side.
the cardiac output monitoring,
Very good.
uh, like via esophageal Doppler and pulmonary artery catheter.
Okay, cardiac output is one thing. CVP,
Mm,
invasive blood pressure. Okay.
invasive blood
Then
pressure,
neuro
urine,
monitoring, neuro
neuromuscular
monitoring,
monitoring.
neuro monitoring. Neuro monitoring is in the form of evoke potentials, in the form of BIS. Okay.
Mm, yes.
And this will usually it occurs by a special department. It's called as
Mm,
physiology department.
physician.
Okay. And they are
Okay.
doing the EPs, BIS and EEG. Okay.
Easy.
They are monitoring it. If they are using, and then you are using the TIVA. Okay.
Yes.
So what else? Then urine output,
Your output. Yes.
temperature. Temperature
Temperature.
sometimes is come in
Standard.
temperature. Sorry, no, not temperature,
Standard.
because temperature is in the
Standard two.
standard standard two. Urine output. Then what else? As you told, neuromuscular.
Monitoring.
Okay. What
Via top.
else?
Mm.
You
Hmm.
are monitoring. Sometime in the neuro monitoring, you are also monitoring the ICP. Okay. You are also monitoring the cerebral perfusion
Well,
pressures.
how
Okay.
how we will monitoring cerebral perfusion pressure via
Cerebral perfusion pressure
catheter
with
and
the
catheter.
stump pressure, stump pressure, stump pressure in as we do as they do it in carotid endarterectomy. Okay. And they are also doing it with the EEG, because if there is any problem, there will be change in EEG. Okay. So neuromuscular monitoring, and what else? Any compartment pressures monitoring. Like for example, if they have put the tourniquet, so tourniquet related pressure monitoring and time. This is also part, this is your responsibility. Okay.
Yes.
Then uh, this may not be coming here, but any throat pack which you put, this is also monitoring. You have to remove it at the end. Okay.
And when bleeding sponges, gauzes, that are
Yes.
also part of
Bleeding
monitoring.
assessment. Bleeding
Bleeding assessment.
assessment. Okay. What else? My mind is slightly down. I'm not recalling some of the things. Any other sort of monitoring? Anyone which we are missing, please? Zishan, is he around here or left already? Yes, Zishan. Any special monitoring which I have missed?
I'm sorry, sir, मैं थोड़ा सा distracted था.
Maybe
Didn't get it.
monitoring. Okay, if I recall, I will tell you again. Okay. So yes, point of care testing. What is the concept of point of care testing? What
Tag.
what is the concept
Sir,
of
we can
point
do
of
tag and rotem.
tag or rotem? What else? What else is point of care testing? Quickly. Yes. Have you heard of
Checking
HemoQ?
of
So
blood
it
sugar, like
Sir,
on the
Blood
HemoQ,
spot
sugar,
and
glucocheck, ABGs,
urine,
and
urine
checking routine.
dipstick test. Okay, ABGs, ACT. There is also provision of doing INR. This is also part of point of care testing. So always think, whatever surgery you are
use of ultrasound and examination of flu status by
very
CVP
good. T.
and
T
or
and
inferior vena cava
ultrasound.
ultrasound.
Yes. So this is also point of care testing. Point of care testing in the form of blood sugar level, urine dipstick, ABGs, ACT, INR. Okay. Okay. In the monitoring, I forgot to tell you about intra-aortic balloon pump. Okay. In very specific patients, a very high risk cardiac patient, there may be use of intra-aortic balloon pump. This is maybe high-fi thing, but you just keep thinking this in your mind. Don't tell in normal patient this thing. This is in a very specific scenario. Okay. So
IABP will be considered in a monitoring? Isn't it a kind of a treatment or a procedure?
and you see that
Curative, no?
yes, but if the patient,
It's
for
both.
example,
Both is, yeah. I just want to interrupt. It's both. It's monitoring as well as emergency treatments for or bridging of that patient which has acute coronary syndrome, going for cabbage, or patient with severe heart failure, bridging for the heart transplant. At the same time, you can use as a monitor.
monitor in the form Zishan, because this patient, there is a complication, known complication of rupture. Okay, so this patient can have quickly there. This patient can have is at more risk of arrhythmias or failure. Okay, so this thing you have to consider. You have to be very cautious if the patient has balloon pump. Okay, and this is more true now in ICU. Okay, in this is in this patient might be in ICU. Okay.
Yes, sir. Sir, it shows also like a A line. Same the graphic, same the picture
Yes, yes,
showing.
yes,
Yeah,
yes,
that's
yes.
why you can monitor as a A line.
But I told them that actually the chances of being asked in the postgraduate exam of anesthesia is very least likely, but just to make a concept about it. Okay. So any special perioperative care needed, and any, as I discussed this thing yesterday as well, anticipated problems, anticipated perioperative complications which you can have. When you are take again, I'm repeating, correlating it, that if you have a history of something, you can anticipate something. Like for example, if you're a patient with diabetes, the anticipated complication is autonomic, because of autonomic dysfunction, swings of blood pressure. So this is the anticipated thing. A patient with diabetes mellitus can go in hypoglycemia. So this is an anticipated thing. Can go in hyperglycemia as well. This is an anticipated. When you are giving insulin, this patient can go into hypokalemia. This is anticipated thing. So these are the things which you have to think when you are, again I'm repeating again and again, while taking history and doing examination and interpreting the
Sir,
investigations. Yes.
the perioperative means in preoperative, intraoperative, and postoperative. Three will be in this category of
Yes.
perioperative.
Yes. Yes.
Okay.
Yes. Okay. So actually, I will give you an example, that if you have a patient with a fracture, even in pre-operative period, while you are transferring the patient, okay, patient can have embolism. Okay. So you have to take care of this patient. So similarly, you can put it in, because don't overdo it. Even if you, if it is not fitting in every category, still it is, these things should be in your mind. Don't You don't need specifically the step of at which it can occur. It can occur at any time. Okay. So this is just to tune you, that in certain, like for example, if you are taking a patient with asthma, you can expect high airway pressures. You can expect intraoperative bronchospasm, reactive airway. You can expect exaggerated reflexes. So this is how you anticipate. Okay.
Okay.
Okay. So in any patient, you have to make an analgesia plan, uh, regional anesthesia plan. Okay. Or then these are the things actually we discussed yesterday. I will just try to finish this, correlate with from where we started actually. Okay. We started with the, just a second. These are the, you will find these question written, and you can correlate this file with the other file. It's there in the link. Okay. uh, and it is better you read it, and then you make your own questions that you can make in your own way. Okay. Just a second, please. Yes. This was the way up till now which we discussed, what from direct patient, and this will be the sample of the data which you will be finding. Okay. So like this patient is for subtotal thyroidectomy, and a history of heat intolerance. Okay. Palpitation, lethargy, weight loss, and she has received radioactive iodine before, and also has sickle cell trait, because usually in their long cases scenario, they international exam, they combine one or two diseases. Okay. But for us, you will be finding a similar sort of thing, patient with the data interpreted after taking history and examination, you will find this thing. Okay. So what is you will be thinking about, because if the patient is taking anti-thyroid medication, you are anticipating that this question they will be asking you in the exam. Why in the this first part of pathology part of that, what is the mechanism of action of carbimazole? What are the side effects? Okay. So if anyone can recall the side effect and mechanism of action of carbimazole.
The carbimazole stops the conversion of T4 to T3
Mm-hmm.
by inhibiting the tyrosyl residue, I think something like that. And
Okay.
the side effects were that number one, it crosses placenta, it will cause hypothyroid in the baby. Uh,
Okay.
and aplastic anemia, it causes bone marrow suppression. And I think hepatic.
Okay, I think if I'm not
Hepatic.
remember recall, I'm wrong, there is also a granulocytosis. I'm not sure. I cannot recall it, but I'm just giving you example. And other antithyroid medications like propylthiouracil, because if the patient is taking carbimazole, they can ask you about propylthiouracil as well. Another thing is that it is a pro drug. Usually, methimazole and carbimazole are I don't know which is the pro drug and which is the active drug, but methimazole and carbimazole, one is pro drug
Carbimazole
and
is
what is the active drug. Okay. And
Methimazole is a
OC,
prodrug, I think.
carbimazole is.
Carbimazole.
yes. Okay. So OCPs, if you have history of OCPs, this patient might have risk of embolism. Okay. So now examination, when you have taken the history, you will be saying in the same way that my patient is 30-year-old female, presented to the emergency or ward or OPD with this finding, and these are the positive findings. The blood pressure is this one, vitally stable with blood pressure of this, heart rate of this, respiratory rate of this, well oriented in time and place. Okay, and then you can tell the positive finding that patient was presented with some signs of heat intolerance for last, which started this time, and there are associated symptoms like this time. Like, you have to explain your patient like that. Okay, so that you will have similar data like that, and at the same time you will be asking the examiner to give you the labs. So labs you can find, and you should be knowing what are the reason for doing the labs. Okay, like for example, if you are telling about hemoglobin, you will say that to see the status of hemoglobin level, because
Platelets.
if it is low, there are chances of low oxygen carrying capacity, and the patient is already hyperthyroid, so maybe patient have some chances of patient going in atrial fibrillation and heart failure. So this patient needs a good hemoglobin level. Okay. Similarly, white blood cells is related to infections. Platelet count is important if you are giving regional anesthesia. So both qualitative and quantitative function should be normal. PTINR, as we do in when we are anticipating any liver involvement. Okay, and electrolytes, especially if the patient is taking any diuretics or patient is having any problem in which electrolyte
PTU.
can, sorry.
Propyl thioglycerol also causes the deranged LFTs.
Yes, yes, that's why they have done it. Okay.
Mhm.
So, so like CBC, LFTs, RFTs, electrolytes, and then the specific investigation for it is T3, T4, TSH. Okay. So if you have a hyperthyroid patient with very reduced TSH, so maybe this patient needs some more optimization actually. But here they are, with surgery, they are uh, telling some, maybe this patient needs some optimization, if I'm not wrong. Okay, so in the ECG, in this ECG, are you finding anything? There is tachycardia, the rhythm is sinus, or no?
Sinus? Sinus?
Hmm? Anyone who is very good in ECG, because there is definitely tachycardia around 140 something. There is atrial fibrillation or no?
Yes, sir, it is it. AF look like.
At atrial fibrillation, yes. No P wave.
Atrial fibrillation or atrial flutter?
That's flatter because rhythm is normal, I think.
It is most probably it is flutter. Just we will just have a look here. Just a sec. Okay. Narrow complex
Sir,
regular
he has written
tachycardia.
flutter, but I didn't understand why it was written flutter here.
Okay, I will tell you. Just a second. Is there any
Because
P
in
wave in this?
flutter, we usually see the characteristic sawtooth appearance of P waves.
Let's say just in the rhythm lead, just see. There is no P wave. Heart rate is more.
If the rhythm is regular and there is no P wave, then it's flutter.
It may be SVT. You are absolutely right. I'm not very good interpreter of ECG. Okay. But for SVT, I think there should be more rate. I don't have convincing evidence why it is not SVT. Any other comment about it?
Sir, I think atrial flutter will be having more heart rate, more than 300. SVT will be less heart rate.
Nee, that is only
No,
for
not
the
it's
atrial heart rate,
opposite.
not the ventricular heart rate.
Sir, I think madam say opposite. In SVT, there is more heart rate as compared to flutter.
Okay, how much heart rate is estimated in the SVT? Can be estimated.
In flutter, it is around about 150 to 200, and more than that, it's lead to SVT.
SVT can be on 150 also,
No, as she is
40,
right.
150 even.
Atrial flutter has more heart rate. Okay, I think this is a doubtful thing. Okay,
But that
so
is
please.
atrial rate, sir, only.
Yes, atrial rate. Yes,
Atrial rate is more than 300 in atrial flutter.
yes.
Okay. Okay. So that's how you can summarize that this patient is having thyrotoxics and anemia, who is known to have a sickle cell trait. Sickle cell trait. What is difference between sickle cell trait and sickle cell anemia? Homozygous and heterozygous. Okay.
Sickle cell trait is homozygous.
No,
Trait is
It's not
heterozygous with no symptoms,
heterozygous.
heterozygous.
clinically normal.
Heterozygous. Okay.
Mm.
So,
Okay, so as I told you, apologies for this ECG. I also have some doubts, but because I'm not convinced, I will not say anything. In first look, I say it flutter. Okay, but there is some doubt. So just don't consider this ECG. We will discuss ECG separately, inshallah. Okay. So as I told you that this patient needs optimization because thyroid TSH was too low. Okay. So prior to such thyrotoxis should be controlled by optimizing drug therapy. She needs further airway assessment and further investigation such as nasal endoscopy, thoracic inlet X-ray and CT scan as indicated from the clinical history and examination. The full blood count shows pancytopenia which may be related to carbimazole. Okay. So for further evaluation of thyrotoxicosis, what test you should be needing, maybe not written here, X-ray neck, lateral view, okay, also nasal endoscopy as they have told you, and the CT scan to see any airway distortion and extent of the thyroid. Okay, what else you need to do? Anything up till now you need further? Okay, so actually,
On ECG, on ECG,
yes,
sir, most common presentation of hyperthyroidism is atrial fibrillation.
atrial
It can be
fibrillation or
atrial
atrial
flutter,
flutter. Atrial
atrial flutter.
fibrillation or atrial flutter. So that's why actually, because I had read this book before, so that's why maybe 5 years ago, when I appeared in Irish fellowship exam, I had read this book. So the some memory, so I just picked it up that I remember that it was written atrial flutter. So that is why actually I personally I don't think that one book is a good one book reading is never a good source because you can be confused. So just compare if anyone can Google at the moment about atrial flutter and this SVT confusion, it will be easy. Mine,
sir,
I'm not. Yes.
sir, there is a
Flutter will have
specific
sawtooth appearance.
article flutter is star tooth-like appearance.
Hmm. And what about heart rate?
Sir, definitely, what I study is that arterial SVT has more heart rate as compared to arterial flutter.
Okay. Okay. Anyways, just leave it for a while. We will discuss it later. I will confirm it and I will tell you. Okay. So then the questions which they will can be asking you about What are the causes of hyperthyroidism? What is the pathology? How thyroid hormone is synthesized? Can anyone tell about it? How thyroid hormone is synthesized? Okay. Okay, as you see here, that there are T4 and T3. Okay, the first step is iodide trapping, which occur from the dietary source, and then it is concentrated in thyroid follicles. The next step is oxidation. Iodide is rapidly oxidized to iodine. Okay, and then there is formation of iodination of tyrosine with monoiodotyrosine and diiodotyrosine, and then they combine to make triiode T3 and T4. Okay. What is controlling the release of T3 and T4?
TSH.
TSH. TSH released by the
Posterior pituitary.
Anterior
anterior
pituitary.
pituitary.
Posterior
Anterior pituitary. Anterior pituitary. And it is controlled by
TRH. That is
Hypothalamus.
released by hypothalamus.
Hypothalamus. TRH.
THRH, thyroid hormone releasing hormone. Okay. So from hypothalamus, THRH, then go to TSH, and then TSH is actually THRH is for negative feedback. Okay. So that's how it thyrotropin releasing hormone released by the hypothalamus when the T4 TSH is production suppressed from a negative feedback loop. So this is the question which they will be asking you. What is the half-life? Or T4 is 5 to 7 days and T3 is only 24 hours. T3 is 4 times more active than T4. This is the most important question they will almost ask to every patient. Okay. So what are the possible causes of hyperthyroidism? Okay. This is another question they will be asking you. Uh, Graves' disease, toxic multinodular goiter, solitary toxic nodule. Okay. All thyroiditis causes hyperthyroidism except one. What is that one?
Hashimoto.
Anyone? Hashimoto. Okay. Hashimoto thyroiditis cause hypothyroidism. Okay. And among the anesthesia drugs, amiodarone cause thyroid dysfunction. Okay. So, and it may be exogenous iodine also, and also if patient was hypothyroid before and now taking overdosage of thyroid hormone, it can also present it in the form of hyperthyroidism.
Iatrogenic.
Okay. So you have to they can ask you why hemoglobin is low, or why this one there is decrease in white blood cell counts, and you can say that patient was on carbimazole. Okay. And as I told you that this patient needed more optimization before elective surgery. And carbimazole mechanism of action they have written here. Because we have taken a lot of time, I will just try to summarize it. You can have a look. But the question, yes, what is the role of beta blocker?
Prevent conversion.
Block the conversion, peripheral conversion of T4 to T3.
Okay, who was talking? Rajanan, you want to speak out?
Sir, I was saying same. It prevent conversion.
It is only for conversion.
T3. It also prevent tachycardia.
This is the
Symptomatic
more
relief.
important thing, and that is the less important thing. You are telling them less important thing first, and more important thing you are telling after what I'm pointing it out. Mainly, it is given for the metabolic symptoms. Okay. So, but also it and what medication is it? All beta blockers or non-selective beta blockers?
Non-selective. Actually,
Non-selective.
ideally is propranolol.
Propranolol.
And
Okay.
the most important, our effect is decrease the sensitivity to the sympathetic nervous system.
Yes.
decrease the risk of arrhythmia.
Yes. Okay. So it is also to control the for atrial fibrillation. Maybe you need further more than this beta blocker. You might need to treat if there is atrial fibrillation. In addition to beta blocker, maybe the patient needs digoxin, or if there is development of clot, the patient may be on warfarin or things like that. This is a separate topic, but you should be thinking about it. That if whenever there is chances of atrial fibrillation, clot, anticoagulation according to the scenario, according to the presentation. Okay. So anesthesia implications. Now, up till now, we have just covered, because this is how the case will be presented to you. You will take the history, you will do the examination, you will see the investigations. In addition to whatever investigation we have told, ECG we did not tell in the that in this patient we need ECG. And if you find anything, any sign, you will be going any further risk factors, you can do echo. Okay. But usually, if there is no multisystemic involvement, there is no risk factor, echo is not mandatory in every thyroid patient. Okay. Unless there is some, because echo is not indicated in every patient. You can say that if there is some risk factors, then you will go for echo. Okay. If there is low MET, or there is more risk factors like insulin dependent diabetes mellitus, or a history of CVA or renal failure, then you will be doing it. In addition to
The
the
risk factors will be decided on the least cardiac risk device index.
yeah, the least risk index and the intermediate risk factors are the same. Okay. There is no difference. It's the same. Revised cardiac index only at the emergency surgery. There is two numbers for that. There's 2 points for that. Okay. So it's the same thing. Lee revised cardiac risk index is the same as in a clinical risk
As
factor,
intermediate
is the same like
risk
intermediate predictors. They are same. Okay. So that's how I have tried to gather, because I am telling you in a different way. If you are discussing this case with some other people, they will be telling you to the point, the exam oriented thing. But if you have the concept, believe me, then in the exam you will be able to answer anything. If you don't have the concept, the
Excuse
cramming.
me, sir. Actually,
Yes.
I was disconnected. Have you discussed about the pathophysiology, or what is the pathophysiology of engraved disease, about exophthalmos or myxedema of the tibial, anterior tibial, and have you discussed about these all things? Because I was
Some of the
disconnected.
things. Some of the things you can tell about, if you can highlight some of the things. In Graves' disease, there is autoimmune destruction. There is autoimmune involvement. Okay. So
And the same antibodies can cause inflammation, what you say, to
yes,
retrobulbar, yes, inflammation.
and there
And
is
even if
destruction
there
of
is
the
a
eye muscle.
control level of thyroid function test, even then it causes the exophthalmos, because it's not related to the only the hyperthyroidism or hypothyrotoxicosis. It's related to the antibodies. If there is
Yes,
antibodies, even if the disease is controlled, it can cause exophthalmos. And the tissues in the retrobulbar, the antibodies they deposited, and there they cause inflammation, and that inflammation cause the globe to push outside, and it causes exophthalmos. There's retraction of the upper lid, difficulty in closing. And we, regarding our concern about this, is intraoperative. We have to
take
clear
care of
about the
the
corneal
corneal tear,
diseases.
and even we might need to have tarsorrhaphy.
Yes, that's right.
Okay.
Even sometimes the patient came with some cloudy, this is the cornea, this. The same mechanism is when there is mixed edema on the anterior side of the tibia. The other side of deposition of these antibodies is anterior side of the tibia. Third is
It is
I
called
don't
as
know exact what is
peritibial myxedema.
pretibial mixed edema. Yeah. And the third things is also the increase of the soft tissue in their fingers. And the patients with Graves' disease, same like in acromegaly, their fingers are what I think, I don't know. So what is this? Some brachy like this, but the soft tissue increase in their fingers also is also related to the antibodies of the present in the grave disease.
Okay, thanks. So actually, they will be asking you some details, okay, of about the causes, but usually their questions will be about how thyroid hormone is produced, what are the most common causes of hyperthyroidism or hypothyroidism, and then how you will be interpreting the airway, how will you be interpreting the when will you will be not doing the case if the patient is not optimized, heart rate is high, there is atrial fibrillation, TSH is too much depressed, then you will not do the elective case and you will further optimize. At least 4 to 6 weeks are required for the optimization at least. Okay. But if, for example, if it is a mass, if it is a cancer, then maybe sometimes you need to remove it because otherwise it can cause airway compromise. Symptoms will also be telling you that, for example, if there is a respiratory breathing problem, then you may not cancel it for a long time. Okay, so that's why the concept of multidisciplinary team and discussion with the surgeon is always of prime importance. Okay. Okay. So
Just sir, if you allow me, if somebody can also, discuss about men one and men two, because sometimes
Jamil, we don't have time.
it will be
Unfortunately,
the
we don't have.
okay,
No,
okay, no problem.
already uh, I'm almost out of my words now. I have sore throat, so I may not be able to. And we have almost covered at least more than 90 minutes. We have covered. So if anything missed, we can discuss further. I have discussed these topics before as well. Okay, and I can have some further session. But I just my purpose of this discussion was to give an overview how to approach a long case. Then they will be asking you and each it's every step, like we have discussed here before, that in this patient there will be exaggerated cardiovascular response, so you have to blunt it. The anesthesia implication will be that, for example, if there is large thyroid, when you remove it there are chances of tracheomalacia. Okay, if it is prolonged thyroid, there may be tracheomalacia, and that's why you are also mentally prepared for post-operative HDU care. This is one thing. And another thing is you have to do the leak test. I'm just trying to tell you quickly so that all important things are covered, which they will ask you. And for example, if you extubate, before that you have to do a leak test. You deflate the cuff, and then there should be some air leak from the sides of the tube. If it is not there, then there is chance that this patient might have some respiratory problem. So in that case, if you extubate it and also after that you face some problem, you can do the patient put the patient on the side, or you can have ENT surgeon on board so they can relieve the obstruction by putting the rigid bronchoscope. So these are the things which you should be thinking about it. And there are availability or provision of patient needing post-operative ventilation, or may need tracheostomy, for example, if airway collapse. And for example, or you are anticipating, this is actually surgical domain, but from your side, tracheostomy, rigid bronchoscope, lateral, and air leak, positive air leak test. These four things you should not never forget. And then is about the recurrent laryngeal nerve damage, hoarseness or stridor, or risk of aspiration, things like that. Okay. So this we have already
I just
discussed.
want to add one thing, except rigid scope in case of there is suspected of tracheomalacia. There is one
Mhm.
medical entry hook, the same like bougie, but he has hole on the tip. You have to
Okay.
also stand by if there is very large or huge
Uh, Jamil, we cannot
thyroid.
hear you.
And in
Jamil,
case of
unfortunately, we
tracheomalacia, you
cannot
cannot
hear you.
put the ordinary tube. You just go with. Sorry, sir.
Again, please.
Might be the signals at the entry hook. It's same like bougie, And if you don't have the rigid bronchoscope, you can put this hook, medical hook. And the difference between the bougie and this hook is there is is inside there is a hole, and you can also the ventilate the patient with this hook, same like bougie.
Okay.
It's
Okay.
called as
Okay.
medical entry hook. Yeah.
Okay, and one more thing I will tell you, that there is a specific endotracheal tube which has electrodes placed in it, and it is placed in a way that it is touching the vocal cords, and intraoperatively and even post-operatively they can monitor before extubation whether the vocal cords are working or not. In that case, you're not giving any muscle relaxant in that time. Okay, so you have to convert into TIVA, and and there is this specific endotracheal tube with electrodes. Okay, these are actually,
It's called as
Jamil.
Nymflex. His name is Nymflex. It's neuromuscular monitoring also.
Okay.
Sorry, not neuromuscular. This neurological monitoring. When they use the harmony, and if they touch the nerve, the electrodes detect, and they show that you are touching the nerve.
Your sound
And
is coming
the
very
other,
slow. Jamil, you have to be a little loud.
okay, sir. Now is it okay now?
Yes.
Yeah, this ETT called as Nemflex. There is definitely, you already explained that there is some electrodes, and it's connected to
Okay.
same like. Yeah.
Okay, Jamil,
And
we are short of time now. I have to finish. If anything extra you are to tell, please. Otherwise, we have to just finish it. Okay.
the other thing, I just, sometimes they ask about the ligation of the superior thyroid artery and inferior thyroid artery. IMA. In superior case, they have mostly, the surgeon try to ligate as near to the thyroid gland, because it's coming parallel with the superior laryngeal nerve, and there is risk of ligation of that nerve. That's why the surgeon try to try it as close as to the thyroid gland, and opposite to the inferior thyroid artery, they close as away as to the thyroid gland, because in inferior side there's a recurrent laryngeal nerve, and it also goes parallel to these arteries. And if it's away from the thyroid gland, they ligate, there is a less risk of recurrent laryngeal nerve injury.
Okay. Thank you. Thank you. Okay, so I will just try to conclude it quickly, please, because we are short of time now. It's quite a long session now. So we will discuss thyroid in detail separately, because in this case I was actually trying to give you an overview how to present a long case. Okay, so it's not possible to cover whole of the thyroid. So we will do thyroid separately. So these small things we will discuss. Okay, so usually in the perioperative management, they will be asking you these things, and then post-operative problems you have to anticipate. As I have told you, that you have to expect that this patient can have post-operative complications because of removal of the parathyroid hormone. This will occur after 48 hours. Immediate complications are related to airway compromise. Okay, so this is a very common question which they ask you, that after removal of the tube there is airway difficulty, and how will you manage it. Okay, so apology, because now I am tired, I have to finish it. We will discuss that the thyroid case separately in detail. My purpose for this session was give you an overview, and I will just summarize whatever we discussed, that there is some default history taking which you should be doing in any thyroid patient, and any patient, and then how to interpret these findings, and how to tabulate the risk factors, and then how to anticipate intraoperatively in something you need to prepare in preoperative period, how to conduct anesthesia in intraoperative period, and how to give the care in postoperative care. This is how they will be asking you. They will be asking you about the pathology, the common causes of anything, whatever they are trying to ask, the interpretation of the investigations, how to optimize the patient, and how to prepare the patient for the surgery. Okay, so thank you very much, and inshallah we will meet again. Okay, thank you. Bye bye.
Thank you, sir.
Thank you.